ahead of me. He's sharing his screen.
Just stop your
So,
sharing,
what?
okay?
That's okay. Hi,
Oh,
Chris. All good. I'm just going to introduce Matt Scriba. He's the second consultant in upper GI and has taken on the role of, um, shall we say, physiological testing in upper GI diseases. And he's running our impedance and pH and manometry setup. He is a very practical chap, explains things well, and on behalf of the Gastro Foundation and Project Echo, we welcome him to the forum. He's been on it before. Please post your questions in the chat, and it'll be open for questions. And remember that it is recorded and that you can watch it at your leisure or refresh your memory after the event. Matt, please share your screen and let's get going.
thank you very much. I hope you can all see that.
Okay.
Thank you. Okay, so good afternoon, everybody, and thank you for joining us. I am going to keep the chat open on a second screen here so I can see if anybody has any questions throughout the session. If something doesn't make sense, please write it in the chat. Then I'll try and keep it somewhat interactive, and then I can answer any questions as they arise. So I've been asked to, I know this is an endoscopy session, but a big part of endoscopy revolves around diagnosing reflux disease, pathological reflux disease. And when the scope doesn't give you the answer, we have to revert to pH plus minus impedance testing in these patients. Now, I must be honest, when I took over the motility service from Dr. Sasabota, I was intent on not doing any impedance testing. This is because, unlike a straightforward pH, it takes much longer to interpret, and I'm not sure I would have had the time. And also, often it's most useful in patients who have mainly functional disorders. And as a surgeon, these are the type of patient I actually really want to stay away from, to be quite honest. But since doing it, I've realized that impedance testing is actually extremely important and very useful in some of these patients. And for the most part, I think there's a lot of confusion around impedance, especially what it actually does, what is useful for. So I want to give you a practical approach to pH and impedance today. I'm going to talk about acid reflux firstly. Excuse me if this seems very simple and basic, but this is how my mind deals with acid reflux. And I do think it's often very poorly understood in terms of, especially when we try and diagnose patients with it. I'm going to talk about the Leon 2.0. So that's the second version of the Leon International Consensus, which is the most up-to-date international guidelines we should be using to diagnosing reflux disease. And then I'm going to go through pH and impedance testing, try and imply or show how one actually does them, what it actually is about. And then I'm going to show 4 quick cases at the end to highlight how these tests are done, how we do them, and how they can change the management in the patient. So we all as human beings have acid going from our stomach up into our esophagus. It's completely physiological and normal. It happens up to 40, even 80 times every day. And we have to ask ourselves when you see a patient, well, at which point do we call this now abnormal and offer the patient therapy? So here's a little diagram that kind of how my mind thinks about what happens when we eat and when we swallow. So whatever we eat and swallow should go down nicely if we have normal motility of our esophagus down into the stomach. And if we have proper functioning LOS, lower esophageal sphincter, it should open nicely. Whatever we eat should pop into the stomach. We should also have a normal functioning pylorus, which generally stops things free flowing into the duodenum and beyond. Otherwise, we get dumping syndrome all the time, which some patients have. And so you build up whatever you've swallowed in your stomach. Now, if you have enough of it, and after a while, it wants to head back up. And hopefully we've got a well-functioning lower esophageal sphincter that is closed and can prevent reflux and redivert the food somewhere else, back into the stomach, And we also hope then that the pylorus can intermittently open and empty the stomach. Now, why I'm showing this is that when we think about reflux, we think, well, it means in pathological reflux that we have too much acid or gastric content going back up into the esophagus. And therefore, the problem lies at the lower esophageal sphincter. Hence, we always think whether this patient needs anti-reflux surgery. But we have to remember that if we have a problem distally at the pylorus, the stomach itself, or even distal to that, gastroparesis, gastric outlet obstruction, this can stop the contents draining properly and you can increase reflux into the esophagus. So we do have to recognize that a problem here can also cause reflux. And that's obviously something that isn't correctable with anti-reflux surgery. So just to keep that in mind. We always show this picture to our registrars when we train them for the finals to show the many mechanisms we have in place physiologically to stop reflux happening at the lower esophageal sphincter. I'm not going to go into detail today about that, but just to bear in mind, there are many things that can go wrong that can cause us to reflux. Now, Leon 2.0, here's the reference for it, was brought out at the end of 2023, so it's just over a year old. It's quite new. And as I mentioned, it's the second version of the Leon classification. And basically, this is a group of experts, gastroenterologists, surgeons, etc., who came together and came up with a consensus guideline on how we should be diagnosing pathological reflux. Now, this has got nothing to do with treatment. So there are other guidelines for treatment. There are other guidelines for who should have anti-reflux surgery, like the Icarus guidelines. Today, I'm going to focus specifically on the diagnosis. So this is what the focus is about. So I'm going to show you two tables from the Leon classification that sum up almost everything we should know from that document. The first is this table showing us how important the type of symptom is. So taking a good history is important. So on the left here, these green boxes here show us that what we consider typical symptoms of reflux are heartburn, regurgitation, and chest pain. All the rest are atypical. And what that means is that as you become more atypical in your symptoms, the less likely you are to have a positive pH or impedance test. So we like to have patients, if we want to prove reflux, with typical symptoms. And you can see that they still advise that we give the patient a trial of PPI, but only if they have typical symptoms. There's no role in doing it for these because the response, even if they have reflux, to have the symptoms treated with a PPI is extremely low. And then there's a number of other things that they suggest how we should go about doing that. So I'm not going to talk too much about that, but rather focus on this rather large, busy-looking slide. This is the table from Leon 2, where they've summarized very nicely what they consider, if we look on the left here, to be conclusive evidence of reflux, borderline, adjunctive, or evidence against. Now, the other thing they've added, which is new to Leon 2 from the first version, is what we should do with patients who already have proven reflux, are on treatment, but aren't really responding. And if we retest them on therapy, what sort of thresholds should we consider to be normal, abnormal, etc.? So I'm going to ignore this part for today because it becomes a bit complicated. I'm just going to focus on this side here and just break it up quickly. Now, there are really only two things that prove pathological GORD, and that's endoscopic findings, and those are findings of mucosal damage that's already occurred. So this is LA grade B, C, and D esophagitis. So in the past, we did not consider B to be confirmatory or conclusive evidence of reflux. We do now. There's enough evidence to show that true LAB esophagitis does prove reflux. Barrett's or a peptic stricture. So these are the three endoscopic findings that mean, yes, there's reflux, it's pathological reflux, and therefore we don't need to proceed to do a pH or impedance. You can manage the patient for reflux. I would like to say, it's very important, that if you have severe grade D esophagitis, and it looks like the whole esophagus is involved, please carefully look distally because you might be dealing with a gastric outlet obstruction or a gastroparesis or something else. That's not just pure OG junction problem causing what we would think as typical reflux. If we don't have any of these and the scope looks normal, then we are thinking, well, does this patient have non-erosive reflux disease or NERD? And in that case, we have to do a pH or pH impedance study. And the only marker we really look for is an acid exposure time of more than 6%. That means for 24 hours of the day, 6% of the time, the patient had a pH of less than 4 in the esophagus. That is what we mean. And that's the one metric we now use that really gives us the definitive diagnosis on a pH or pH impedance study. On the other end of the spectrum, what proves that it's not reflux? And there's not too much. You can see we can't really use a scope to exclude reflux. A normal scope does not exclude it. Neither does a high-resolution manometry. So remember, manometry doesn't prove or exclude reflux. It's not part of the diagnosis. It is part of the workup because we want to exclude dysmotilities. And if we're going to offer anti-reflux surgery, we definitely want to know what is happening from a peristalsis point of view. Now, those that have an acid exposure time of less than 4% on their pH study or reflux episodes of less than 40 per day are considered truly negative for reflux. MNBI stands for a mean nocturnal baseline impedance, which is a specific metric we can look at in an impedance study, and basically looks at the average impedance throughout the period the patient was supine at night. Talk a little bit more about that later, but it's not a marker we focus much on, but it is a useful metric. When we have other things that are considered adjunctive or supportive, now none of these are truly confirmatory, but they do support your diagnosis. So they include seeing a hernia on a scope. I would like to say that if you see a hernia on a scope, it doesn't prove the patient has reflux. It simply means that, yes, they have a higher risk of having reflux. Similarly, taking a random biopsy of the esophagus and it comes back, the pathologist has said that there's reflux esophagitis. This also doesn't prove that there is pathological reflux. If you have a very keen histopathologist, there are scoring systems, and if you do this properly with at least 2 pathologists that have an interest in it similar to Barrett's, then yes, you have much higher accuracy. But again, it's under the adjunctive part of this. It's not confirmatory of reflux. The best is to do electron microscopy. I don't think anybody really does this in clinical practice because it's very expensive. But if you do electron microscopy and you find dilated intracellular spaces, which is the hallmark of reflux on an electron microscopy level, then again, it's supportive but not confirmatory. Findings on a pH or impedance include if we have symptom association, positive symptom association. I'll talk about that a bit later. If the patient is refluxing more than 80 times a day, or the nocturnal baseline impedance is low. Okay, so what that means, talk about impedance, but impedance measures resistance to flow. And when you've got an esophagus bathed in acids, it has a much higher flow rate, so the resistance drops. So if it's chronically low and your mean impedance is low at night, less than 1,500 ohms, then it's more in keeping with reflux. It's another supportive adjunctive bit of evidence. We can get some idea on a manometry, so I'm not going to talk much about manometries today, but if they have a low LOS pressure, there's a hernia, which we can see on a manometry, of course, or there is significantly weakened peristalsis. These are all features that might be in keeping with reflux. It doesn't, again, prove there's reflux. And then everything else we consider borderline. So if there's LAA esophagitis, we know that that's inconclusive because a significant number of patients with physiological reflux, without reflux, will have very mild esophagitis. So that doesn't prove it. And then acid exposure times are between 4 and 6, and reflux episodes are between 40 and 80. Okay, so those prove it. Just a quick note, sorry, those don't prove it, those are inconclusive. Just a quick note on wireless pH studies. So this is the so-called Bravo capsule that Medtronic makes. There are other brands as well, of course. And this is a pH sensor you clip into the esophagus on a scope, and it stays in place for 5 to 7 days. We don't have that here. Not sure many places in South Africa do. It's quite expensive. But that's considered now the so-called gold standard if you're only going to do pH without impedance. But it is more expensive, and the Leon 2 classification has made there's a whole section on how we should be interpreting these wireless studies, but I'm not going to focus on that today. So basically that summarizes how we should go about diagnosing these patients. Okay, and I'm going to focus, of course, today on this middle section here to show you how we do that. So in summary, there's really only 2 things that can prove reflux. Scope with positive findings of esophagitis, Barrett's, or a peptic stricture. I'm going to show you some quick videos of that now, or an acid exposure time of more than 6% on a pH or impedance study. That's it. The following do not prove reflux, and we shouldn't be offering patient's anti-reflux surgery based purely on this. So if we have a biopsy that just shows reflux esophagitis, as I mentioned, this is actually very inaccurate. I've got lots of patients I do pH studies on that have this, that land up having a negative study. Trial of PPI is useful and we should be doing it, but if it's positive, again, it doesn't prove the patient has got reflux, because there's lots of patients who get a placebo effect who respond to the PPI but don't have pathological reflux. Barium swallow, now that hasn't come up anywhere in the Leon classification. That's because it's not part of the diagnosis of GORD at all. We often have radiologists telling us that they've observed reflux during the study. That does not prove pathological reflux. The patients can have physiological transient lower esophageal sphincter relaxations during that time. Some of the contrast can go up, especially when they're changing positions. That does not prove that there is reflux. So please don't operate patients based on a barium swallow alone. Then there's questionnaires and manometry. Very useful. We use them again, but they don't prove GORD per se. Okay, so just a reminder of the ALE classification. So what we have to have is at least one mucosal break of more than 5 millimeters. Okay, so if you have that, or it's more severe, COD, then we can call this pathological reflux. Okay, so here's a reasonable example. So this, if we measure it, is about 1 centimeter. There's some islands above. This is what reflux looks like. So in this case, you don't need to do a pH study. If you have something that looks like this is severe stasis esophagitis. Please have a careful look distally, as I said. So in this case, there was a gastric outlet obstruction distal to that. I'm sure all of you know what Barrett's looks like, but just for those of you that may be a bit unsure, it's non-inflamed, so it's not esophagitis, and you get this sort of salmon-looking, almost red mucosa here. So remember, this is more like gastric tissue. It's columnar epithelium that is through metaplasia has become from squamous to columnar epithelium. Also comes up in flames. That's Barrett's esophagus. And of course, I'm sure many of you have seen what a peptic stricture looks like. So those we don't need to do pH studies for. So now I'm going to focus on what pH studies and impedance is actually about. So very simply put, we put a little pipe like this down the patient's nose. We always do a manometry first. We have to do a manometry first to look for dysmotilities, but also to measure the esophagus, because it's vitally important to put the pH probe in the right place. It should lie 5 centimeters above the top of the lower esophageal sphincter. And it's connected to a little machine like this. You can see it's got multiple buttons on it. This is our MMS Omega recorder. There are other models available, of course. So what we ask our patients to do is push a button when they lie down, push a button when they eat or drink. This big sign in the middle is for the primary symptom that we ask them to log. It's usually something like heartburn, hopefully a typical symptom, heartburn, regurg, chest pain. We can ask them to monitor a second symptom, and this is if they are taking their PPI. So generally only if you're doing an impedance. So it gets connected like this. They carry a bag for 24 hours, which they can't get wet. Otherwise, it destroys the machine. So unfortunately, no showering. And I send them home with a diary that looks like this. And we ask them to detail very carefully what they eat or drink, but specifically what time they do it and when they lie down. This is very, very important. Why is this important? Because if you're doing just a pH test, it's just detecting pH levels in the esophagus. And if you are drinking or eating acidic food or drink, quite a lot of things we eat are acidic, like orange juice, some alcohol, there are other things, and you don't mark that you are dealing with a swallowing time, a time when you're eating, then you might think that the patient is refluxing during that time when they're not. So you have to mark off when they eat or drink because we exclude that segment. This is the tip of the pH catheter, and I want you to take note here. So this circle here is showing us where the actual pH probe sits. And as mentioned, that goes into the esophagus 5 centimeters above the lower esophageal sphincter. And in this case, there's only one pH probe. Okay, this is usually what I use for my catheter-based pH-only tests. And this is what a pH impedance catheter looks like. It looks the same to the patient. They don't know the difference. It's the same size. It feels the same. They push the same buttons, but it can measure something else. So this one has 2 pH probes. We put the top one also 5 centimeters above the LOS, while the bottom one gets placed into the stomach. So this one lies in the stomach and allows us to read gastric pH. And I'll show you just now why that's quite useful sometimes. And you get these 7 metal-looking things here. That's part of the impedance. So this is an impedance catheter as well. So how impedance works is that each one of these metal things, between the two is a zone, an impedance zone. And basically, there is a very small current that gets passed, and the resistance to that current is measured. Okay, so it's resistance to flow. And so when we have 7 of these, we get 6 impedance zones. So we know what's happening not just in one part of the esophagus, but the length of the esophagus, and we know what's happening over time. So we can take note of what's happening in the esophagus. This is what a pH study looks like. This is without impedance. This is an overview of the whole 24 hours. And the tracing here shows us the pH. Okay, and you can see there's a line drawn here. That's the pH 4 line. Anything below that is positive for reflux, so long as it's not the time when the patient's eating. And you can see here, this purple is meal. So these periods are taken out because this is the time when the patient has eaten or has been eating or drinking. We also mark off here any symptoms that the patient has pushed, and those are marked with these brown lines here. So at this point, the patient had a symptom. And what we want to know, the machine does this for us, is when they've pushed that button, have they had reflux within the 2 minutes just before that? Okay, you can't push the button and then have reflux, which is probably what's happening here. That's not reflux causing the symptom. Okay, maybe this would be positive, and maybe that would be positive. So this is how we come about getting symptom correlation. I'll show you how we do that just now. The other thing that's important to know is when the patient is supine, and you can see during this period of time they were sleeping, and the pH actually dropped actually went up quite significantly. Now, this is the printout that the machine gives us when we do, this is just a pH test, not impedance. It looks very busy and confusing. What is all this stuff about? I'm going to simplify it now. So the first thing we look at, the most important metric, is the acid exposure time. Okay, and that's marked here. It's the total reflux time as a percentage of the 24 hours. And in this case, it was 13.4. Remember, I said 6% is positive. So here we've got 13.4%. So this would be positive. Added to that, we look at the next thing is the number of reflux episodes the patient's had. 108 in total. Again, more than 80 is adjunctive evidence. So here we're dealing with the case that, yay, maybe this is a patient with reflux. Maybe we've made a diagnosis. What about the de Meester score? I think many people still ask about the de Meester score. It's very old. It is no longer part of any current guidelines. It's completely fallen away. It's historic. We don't use de Meester anymore at all. So that whole thing goes away. It does not form part of Leon 2.0, and any of the sort of international centers of excellence in terms of esophageal physiology have stopped using de Meester. So we don't use it anymore. So it's much more simple. We use the acid exposure time as our primary metric and the number of reflux episodes as an adjunctive measure. So what about esophageal impedance? So I've drawn a little thing to try and explain what impedance is about. So remember, it's measuring resistance to flow. Now, when you have fluid in the esophagus, the resistance decreases because the current can flow better. The ions can flow better if you have liquid, and therefore impedance drops. While if you have air, there is resistance, so the impedance goes up. So this you can see here. So here impedance is going along. Now imagine some fluid comes along and the impedance will drop like this. And this is what you see on the graph. And then it recovers because the liquid gets cleared by the esophagus. If we have air, it goes up. All right, so the impedance increases. And then once that air gets passed, gets peristalsed down or burped out, it resolves. But now remember, we don't just have one impedance zone, we've got 6 of them. And at the bottom, we've got time on the x-axis. Here's our esophagus with our 6 impedance zones. And so now you have to imagine that each zone is making its own drawing, as I've just said. So I'm going to show you what that looks like. So now imagine the patient is swallowing. So the water is coming from the top. And as it goes down, it causes the impedance to drop. Okay, but in a stepwise fashion like this. And if we have this sort of picture, we know that A, it's fluid and not air, And secondly, that it's gone from the top to the bottom, not from the bottom to the top. So this is not reflux. So we look at the direction that the impedance has changed. Okay, so this is a swallow. If we had a reflux episode, it must come from the bottom up. So the direction is different. Okay, so this sort of angle. The reflux episode looks slightly different. If the impedance goes up and from the bottom to the top like this, then we know it's a belch. So this is a burp. This is an air event. And this is why impedance can be so extremely useful. It can tell us, is it liquid? Is it air? And in which direction it's going. So this is what an impedance trace looks like. This is again for the 24 hours. It looks extremely busy. It can be quite confusing. I'm going to break it down slightly. So at the bottom here, let's just start here. This is similar to what I showed you in the other trace. So we've got 2 pH probes in this catheter. This pH probe is sitting, and you can see that it's sitting at a pH of less than 4 for almost the whole day, and that's normal. That's what happens in our stomach. So we know that this test was done probably off PPI, otherwise this would be higher. And you can see that this pH probe, which is sitting in the esophagus, is basically above 4 the entire day. So this would be a negative study if this is done off a PPI. Okay, so this is the one we're interested in. And then these are 6 impedance zones here. Okay, so Z1 to 6, zone 1 to 6. And they've got different colors. They've got different colors so we can distinguish them from each other. And basically, we need to sub-analyze what is going on in each of these segments, okay? Notice here the patient was supine and they were sleeping, and then the trace usually calms down quite a bit. You can see this patient pushed the button a lot more times, and now we're going to try and figure out from the impedance here whether they had reflux episodes or not. Now, what I would like to say is that when you do just a pH, so long as you fill in the diary correctly and mark exactly when the meals and so were, the machine, the software does the interpretation for you. Basically, it's very accurate. You get an acid exposure time and reflux episode is quite simple. Not so with impedance. If you simply get a printout, you're going to get it wrong most of the time. You have to go into this and we analyze it every 2 minutes of the full 24 hours. And we look at what reflux episodes have occurred, because sometimes the software marks a swallow or a reflux event as a swallow or vice versa. So we have to correct it, and it's somewhat pattern recognition and takes a lot of time. So impedance interpretation can take sometimes 3-4 hours for one study. So it is a lot more time consuming. So here we can see if we've zoomed in now on what's happened here. So here we have an event, some sort of impedance event, and we have to figure out now what it is. So remember the little video I showed now. So the impedance comes along and it drops. Starts at the top, and then it drops in a stepwise fashion as you progress with time. So a drop means that this is liquid, and it's not air. And it's going from the top to the bottom, and it's got quite a sharp angle here. So this is typical of a swallow. So we know this is not reflux. This is a swallow event. And if we toggle something called our contour mode, where the software puts a color to it, which I find is quite useful and quite interesting, we get this sort of picture. It almost looks like a manometry, and it puts the software puts green for fluid and blue for air. It's reasonably accurate with that. And you can see this is a visual picture of what it looks like when the patient is swallowing. Now, at the same time, if this part was dropping less than 4, we would know that what they've swallowed is acidic. Okay, so that gives us an idea. If it's a reflux episode, which I'm going to show you now, and the pH is acidic, then we know it's an acidic reflux episode. So here, this is what a reflux episode looks like on impedance. You can see that the impedance has dropped this time, first from the bottom going up. It sits for a while. It's a much more longer decrease. It stays down for much longer because the acid sits in the esophagus for a bit. And then it gets cleared from the top down because that's how peristalsis clears it. So it looks somewhat like a mountain. And then as mentioned, we compare it to what's happening, remember, in pH 1, not pH 2. This is in the stomach. So in this part here, the pH in the esophagus has actually dropped below 4. So we would consider this an acidic reflux episode. If it was above 4 for the whole time, it would be called a weakly acidic reflux episode. If it's higher than 7, it would be called non-acidic. So this is how we work this out. And you can see here on the contour setting. It looks like a nice mountain, and you can almost visualize fluid going up, sitting around for a while, and then being cleared. And it's acidic at the same time. Right. So there's a comment or a question on the chat here. Let me just see here quickly from Prof. Thompson. So with available of PPIs over the counter, should you do the initial endoscopy with the patient off PPI, and what tests are necessary before considering reflux surgery for the first time and for redo surgery? Okay, maybe we can go through that at the end. I would like to say that if you can, you should always do scopes off PPI, because that's otherwise you'll get it wrong. So that is very important to note. If you are going to make comments about LA reflux B, C, D, it should be off a PPI. Obviously, PPIs are extremely good at treating esophagitis. So if they've been taking the PPI as well, you might well have a patient with pathological reflux. So ideally, you should do it off PPI, and they should be off for at least a week. The tests we need before anti-reflux surgery, I think you need to prove that there's reflux. So either you do that, as I've mentioned now, but once you've proven reflux, I do think we need a manometry. And I do think also a barium swallow, especially if you have a large hiatus hernia, is very, very useful. But maybe we can talk about that at the end about anti-reflux surgery. Okay, what about symptom associations? This is very important because it's one thing to prove that the patient has reflux. It's a whole other thing to show that the symptoms they're having are actually being caused by the reflux. And I'm going to go through some cases at the end to show you where there can be a mismatch between the two. So we use two parameters to prove symptom association. We use something called a symptom index, or SI, and we use something called a symptom association probability, or SAP. The symptom index is quite simple. It's basically the number of symptoms that have an associated reflux event, so positive, over the total number of symptoms. And if this is more than half, more than 50%, we call it positive. The symptom association probability is a little bit more complicated. The software does it for us. It basically automatically divides the entire 24 hours into 2-minute segments, and then does a little Fisher's exact test for each one of those, or does a ratio, and then does a Fisher's exact test of the whole thing. So it's a statistical analysis. And we consider anything more than 95% positive because it's a p-value. It gives you a p-value. So we use both of those together. They should both be positive before we conclusively say there's symptom correlation. If they're both negative, we say it's negative correlation. And if one is positive and one is negative, it's inconclusive. But we have to take into account that if we have a patient, for example, that pushes the symptom button 100 to 200 times throughout the day, and we do see this, then the SAP simply becomes less reliable, and we have to keep that in mind. So here's a full result now for a patient that's had a 24-hour pH analysis. This is without impedance. This is the same one from earlier. So let's just go through the right here. Let's take the mesto away and remind ourselves that we have an acid exposure time of 13.4% and 108 reflux episodes. So yes, this is a positive study. The question is there association with reflux and with the symptom, and here we're going to look at the symptom association, which is on the right here. So you can see the software maps out each time the patient's put the symptom button. So 53 times the patient had a symptom, and it then marks whether there was a reflux episode associated or not. So there's quite a lot of positives here. And you can see that the symptom index was 66%, it's more than 50%, and the SAP was almost 100%, so more than 95%. So this is positive. So great, we have a patient that we've proven has reflux, has symptom association. Go ahead and treat that patient, okay? How you do that, I'm not going to discuss today, whether you should offer them reflux surgery or not. We can maybe talk about that at the end, but basically this is about proving GORD. So the last question here, before I go through the cases, is when should I do a pH only and when should I do a pH impedance? Now, if you listen to the centers in Europe and America, many people say we should stop doing pH only completely and only do impedance and pH. Or if you are going to do pH only, you should do a prolonged wireless pH study. Now, we can't do that. And I do think in our setting, it is appropriate to do pH only. The main reason is it's much cheaper, okay? The catheter for impedance costs, the new quote is around 5,000 Rand per catheter. It's a single-use item. It's very expensive. The pH-only catheters are closer to 1,000 Rand, so much less expensive. It's simply much easier to perform. The learning curve is much quicker than with an impedance. You don't need to sit there and analyze it every single 2-minute period. But it needs to be done off a PPI, and it cannot distinguish whether the patient is swallowing, refluxing, and whether they have any belching disorders, any air problems. I'll talk about that just now at the end as one of the cases. So impedance is much more accurate. It's much more useful in patients who have proven GORD, where you can do the test on a PPI, or the patient simply can't stop their PPI. I have some patients who tell me, okay, you need to stop your PPI for the pH test a week before, and they phone me and say, I simply can't go off my PPI, I'll die, because they're so symptomatic. Or they forget, and they arrive on the day and they say, oh, actually, I'm still taking my PPI. In those cases, you can either rebook them or you can crack on and do an impedance. And of course, we can look at, it's much more accurate, whether the drop in pH is due to a swallow or due to reflux. So let's go through 4 cases. The first 3 are quite quick. The fourth one I'm going to spend a little bit more time on, and then we're going to be done quite soon. So the first case is quite typical, 42-year-old female patient with query reflux referred to us, and she's got typical symptoms, heartburn and regurgitation, so that's quite positive. And her symptoms are really well controlled on a PPI. So already this sounds promising if we want to prove reflux. Now she's developed new epigastric pain, quite severe epigastric pain, and she's convinced it's from her reflux. One thing to say is that epigastric pain and nausea specifically actually have a negative correlation to reflux. So we know that this is very unlikely to be causing, that reflux is causing epigastric pain. On her scope, there was a small hiatus hernia, which we commonly see, but again, this doesn't prove reflux. And she had no endoscopic evidence of esophagitis. What I should probably put here, as Prof. Thompson has mentioned initially on the questions, is whether this was done on or off a PPI. I'm not sure, but let's assume it was done off a PPI. And she went on to be referred to me for a 24-hour pH study. We always do the manometry first, which in this case showed normal motility, normal lower esophageal sphincter function, and we did confirm there was a small hiatus hernia. Okay, but that doesn't necessarily prove anything, so we went on to do the 24-hour pH study off PPI, and her predominant symptom between heartburn and regurg was heartburn, so we put that on, and the second symptom to test now is this new symptom of epigastric pain. So this is what her 24-hour pH study looked like. You can see that there's quite a lot of periods here where the pH drops below 4. This period is very, very, very busy. But note that this is probably around the time she was having dinner. And during this time, she was eating for quite a long period of time, and there was lots of acidity happening. So refluxing while you eat is normal, but it's also possible she could have been swallowing or eating something with a slightly lower pH. Notice also that this is the time she was sleeping. She was refluxing at the initially, and then it quietened down later on in the morning. So when you look at the results, the acid exposure time was 13.3%. That's more than 6%. It's positive. She's got 115 episodes. Again, adjunctive evidence. We're quite happy. So we've got a positive pH study here, which is good. Well, what about the symptom analysis? Well, the heartburn had excellent symptom correlation, which is to be expected. So here we've proven that, yes, she's got reflux and it's causing heartburn. But the epigastric pain was conclusively negative. Okay, so we've shown what we believed at the beginning. Yes, she does have reflux, but it's not causing epigastric pain. So the management here would be PPIs. Yes, I think that she should continue on a PPI. One needs to have a careful look at what's causing epigastric pain. Maybe there was missed gastritis on the scope, etc. Look for gallstones. And yes, she might well be a candidate for anti-reflux surgery, but we should do more tests. Before that, she's had a manometry. Probably I would consider doing a barium swallow in this case before I consider doing surgery, but she would probably be a reasonable candidate for anti-reflux surgery. The second case is a 62-year-old female, also with query reflux. She's got regurgitation as a primary symptom and some dysphagia, but she describes the regurg as terrible acid reflux coming up her body and coming straight out of her ears. So this is very unusual, okay? And when you hear unusual things, my ears immediately prick up and the alarm bells go off. Well, is this really a functional thing? Or I don't know. She also has some other symptoms that are atypical for reflux, like cough and globus. We didn't really interrogate these because these were very minor at the time. And when she was scoped, again, no reflux esophagitis, and the OG junction was called patulous, but no overt hernia seen. Before I did the pH study, which is what she was referred to me for, I did a manometry, which basically was normal, completely normal, no hernia, normal low esophageal sphincter function, normal peristalsis. And so we went on to do a 24 hours pH study of PPI. And what we can see here, it looks a bit similar to what we saw in the other case, quite busy. Okay, she's got some symptoms that she's pushed, very quiet around the time she was sleeping. And we found, well, again, the acid exposure time is positive, more than 6. 78 episodes is on the upper limit of normal. It's not quite 80, but it is probably, I would call that adjunctive supportive evidence. But then we can see that regurgitation, symptom analysis is SI and SAP are both very much negative. And also the dysphagia, which we opted as the second symptom, was negative, less than 50, less than 95. So although this patient has got proven reflux disease, it's not causing her dysphagia or regurgitation. So we have to keep that in mind. So if we are going to offer her treatment, we mustn't be surprised if her symptoms don't resolve because they're not being caused by the reflux. So she definitely likely has a functional element to her symptoms, functional dysphagia, regurgitation, and one has to consider other management, such as neuromodulation or CBT. And I think in a case like this, one should be very wary to offer anti-reflux surgery because there's clearly a big functional overlay here. And this always causes post-operative issues in these patients, okay, because their symptoms are still there. So now you've operated them and they don't feel any better. They're not going to be very happy. The third case is a 67-year-old female, again, query reflux. She's got chest pain and regurgitation, which is typical. These are typical symptoms, but her chest pain is so severe that she's had to repeatedly be admitted to the emergency room. She's actually been admitted to the hospital, worked up for cardiac chest pain on a number of occasions. Everything has been negative, but this is bothering her and affecting her life tremendously now. Scope was normal, other than, again, a small hiatus hernia, which we commonly see. Barium swallow was done in this case, also showed a small hiatus hernia, but was otherwise normal. And I did the manometry, which was normal as well. And when she arrived, I'd initially prepared for a 24-hour pH test. She told me, oh, oops, I forgot to stop my PPI. I'm still taking it. So I thought, well, let's carry on and let's not rebook this poor patient. So we did a pH impedance on PPI, and we used her 2 symptoms of chest pain and regurgitation as the symptoms. So now we're looking at a impedance study. Okay, so let's just take a little bit of time. We did this on a PPI, so it's not a surprise that the pH2 probe, which is in the stomach, is not below 4 most of the time. Okay, so it's sitting above 4 for most of the day. So this patient is probably taking her PPI reasonably well. It is working. The pH1 probe, which is in the esophagus, is constantly above 4. There's almost no episodes here, really, maybe a little bit every now and then here where it might dip just below 4. And the impedance is very, very busy here. Okay, I'm not going to bore you with how we go through it every 2-minute interval, but notice how busy it is here, and it calms down significantly here when she's lying down at night, and she pushed the button a few times for her symptoms. So here's the impedance and reflux result on a PPI. Acid exposure time was 0. Now that's not that reliable now because she's taking a PPI. We don't expect the acid exposure time to be high. If it was more than 4% on this metric, we would consider that positive for reflux. But we can't use the acid exposure time here, so we have to use the reflux episodes. And you can see we now divide them into acidic and weakly acidic. There were 2 episodes that were considered weak as acidic. Now that might be strange because the acid exposure time is 0, but there was probably a little bit of slight drift just below 4 during these 2 episodes. Okay, so one might, sometimes we can say that that's a bit of an artifact and exclude them. But with 2 episodes, it hasn't really changed the outcome here. And we know that the total episodes is less than 40, so we consider that negative. So this patient does not have reflux. We've proven a negative study. And when she pushed the button, she had 2 buttons to push. She didn't push the button once for regurg and pushed it a couple of times for chest pain. And we noted that the symptom index and SAP were both positive. So here's a patient with negative reflux, but positive symptom correlation. And so this meets the criteria for the Rome-4 classification diagnosis of reflux hypersensitivity. This is a functional disorder. Okay. So in this case, we need to look at functional management, neuromodulation with something like amitriptyline or citalopram. There's a role for cognitive behavioral therapy. In places like London, they do a lot of hypnotherapy for these patients. Continuing PPI, it is reasonable because what's happening here is the patient is refluxing physiologically, but when she refluxes, she has symptoms. So one might consider continuing a PPI. Baclofen may or may not have a role, controversial. I'm not going to go into that much now. But in general, I think one should avoid anti-reflux surgery in a patient like this. Okay. There are some cases where people consider this. I would be very, very wary in a case like this because you are exposing it to all the risks of anti-reflux surgery, and your reward, the benefit is going to be quite low. All right. And then the last case, we're almost done here, is a 24-year-old male with reflux who initially presented to us with symptoms of heartburn and regurgitation. Again, typical symptoms, partial response to a PPI, but still had volume reflux. So this is typical. Now we're thinking, well, is this actually volume reflux? That won't necessarily get better with a PPI because the volume doesn't change. It just becomes less acidic. He also initially reported some bloating and lots of winds and dysphagia with an ECOG score of 8/12. So there's a lot going on here. He had an atopic history, was diagnosed with IBS. So there was some another functional diagnosis, and he was quite a high functioning individual studying BCom finance. So his scope was essentially normal other than a small hernia. Swallow was normal, maybe some tertiary contraction, so concern about a dysmotility. He was booked for a manometry and 24 pH study with me off PPI. So just briefly, the manometry was essentially normal. Okay, so here's a single swallow. I'm not going to go at length into this, but basically the low esophageal sphincter relaxes beautifully here, and there's excellent peristalsis. And here's a snapshot of 5 of the 10 swallows we did, which are basically normal. So there's no dysmotility. Here's this 24-hour pH study. Very, very busy. You can see there's a lot of brown. So he's pushed that button many, many, many times. And the pH does dip below here, but not that often, and often it's excluded because of the meal times. So when you analyze it, the acid exposure time here was actually only 2.6%, only 47 reflux episodes, so I would consider that negative. This is off a PPI. And the symptom analysis was actually negative for both regurg and heartburn. So now we have a negative manometry and a negative pH study. And the patient was then referred for repeat endoscopy because of the atopic history to exclude eosinophilic esophagitis, which can present like this, and that was also excluded. 2 months after this pH, he came again almost in a panic because the symptoms were getting so severe, and the predominant symptom had now become burping, belching. He had also increased distal gas symptoms of flatulence, bloating, and he was unable to study properly. It was near the end of the year. Final year exams were approaching, and he couldn't function at all. So because of the belching, I opted to see, well, what's going on with this air? So we did a 24-hour pH and impedance on a PPI, and we used belching and regurg as the symptoms. And basically, this is what we found. Very low acid exposure time, but this is on a PPI. But now suddenly you had a lot of reflux episodes, and they were mainly weakly acidic reflux episodes, 134 of them in total, so that would be positive. So now it's a positive test. And the symptom correlation was now positive for both belching and regurgitation. So what is going on here? Did I do the first pH test really badly, or what is really going on? So what I did then, we have to go and analyze this, remember, every 2 minutes. This is what it looked like, very busy impedance here, lots of symptoms being pushed. He's taken his PPI quite well because the pH in the stomach is above 4 for most of the day. Very little dip below 4 here in the esophagus. This is an eating episode. And then what I found was this very interesting pattern, and this happened a lot. Okay, so what you can see here, the impedance goes up. So this is air, and it's coming from the top down. So he's swallowing the air. And then a little bit later, the air comes back up from the bottom to the top. So this is classic for what we call supragastric belching. So the patient is actually actively swallowing the air, either sucking it in or forcing it in, and then burping it back out. And when we toggle our contour mode, you can see this very clearly here. So here's the blue air going in, and then it comes back out. And more interesting than that, there were quite a lot of episodes where this was happening. So you can see that the impedance goes up here. So the air is coming down, it sits around, and then he burps the air back up. And then it's followed by a reflux episode. So we can see this very nicely here. So the air goes down, comes up, and is followed by reflux. So we know that supragastric belching can cause reflux. Okay, they're actually inducing it. And if you stop them burping, the reflux stops. And this is a very nice function on the software where you can actually make it do an animation of what's going on. And I'm going to show you what this looks like. Look at the image on the right here. As we progress now, you can see over time that the air comes from the top, goes down into the esophagus, there's a lot of air in this esophagus now. He keeps it around, doesn't really reach the stomach properly, and then he burps it back up, and it's followed by this quite pronounced reflux episode here. Okay, and I think once you see this visually, it certainly made me realize that I have to start doing impedances because it's actually really beautiful to see it like this. And in some instances, we saw this going on. So this is not a supragastric belch, but this is just an air swallow. So you can see that the air is being swallowed and it doesn't come back up. It just goes down. And if we see a lot of this is termed aerophagia. So these are patients that swallow a lot of air. They don't burp it back up. It actually goes down and they land up having severe distal gas symptoms like bloating, cramping, flatulence. Okay, and in rare instances, there are case reports of patients perforating their bowel from this. But these are both functional disorders, and there's a bit of overlap in this patient. So again, let's have a look what that looks like. Here the air is going down, whoop, and it doesn't really come back up. It disappears down. Okay. What is very interesting is that this is the period when he was supine, sleep at night. There is nothing going on in terms of these episodes. Not one reflux episode, not one belch. So that is really in keeping with these functional disorders. When you're asleep, you can't swallow air on purpose. And therefore, he had absolutely no reflux episodes at night, which you would expect if this was true reflux. So I counted a total of 146 air swallowing events throughout the 24-hour period. That's a lot. 113 of these met the criteria for supragastric belching. And so the final diagnosis was supragastric belching that was inducing reflux. And the management for this is, yeah, you can keep the patient on a PPI because he is making himself reflux, but you need to stop him belching. And it's often a habit. It's a learned behavior. Often they've got something like a bit of dyspepsia initially, and they realize that when they burp, it makes them feel better. So they keep burping, and they get into this habit that almost becomes subconscious, and they start swallowing air in order to burp. And so you need to stop them doing that. And speech therapy is the way to do that. We teach them diaphragmatic breathing. If you have a patient like this in your consultation room who's burping in front of you the whole time, you need to distract them. So you can ask them to stick out their tongue or put the tongue up against their palate, or you just ask them to put a pencil between their lips. And often they stop doing it. And with diaphragmatic breathing, what you can do is you ask the patient to put the hand on their chest, one hand on the chest, one hand on the abdomen, and you get them to breathe. And they need to concentrate on moving air using their abdomen. So the hand on the abdomen needs to move, not the one on the chest. And as you start doing that and you educate them about the fact that they're actually doing this themselves, you can treat these patients and then the refluxing will stop. So please don't offer these patients anti-reflux surgery. And that's what I have. Are there any other questions? I can quickly discuss this from Prof. Thompson. What tests are necessary before considering anti-reflux surgery for the first time? As I've mentioned, you have to prove reflux, number one. Number two, you have to make very sure the patient doesn't have another diagnosis like a dysmotility, etc., or some sort of gastric outlet obstruction. Please do that. If you're happy this is
Matt,
reflex, then you can do that. Yes.
you can only see your hair.
Oh, sorry.
Oh, that's much better.
Sorry, apologies.
That's quite all right. That's quite all right. I'm not sure if anyone else wants to ask any questions from the audience. We've got about 30 odd participants on the call. I found it very interesting, and it's cleared up a few of my misconceptions about impedance. But I think it's definitely very useful for obviously these aerophagic cum belchers.
Absolutely, yeah.
Yeah, to sort them out properly. I had one question regarding the use of, we're using AI a lot now in colonoscopy and identifying polyps and trying to characterize them with AI. Obviously, the impedance is more difficult to interpret. Is there anybody sort of doing much work on AI interpretation of impedance, or what does is there anything in the Leon classification about AI and how it might make it easier to interpret? Because everybody's
There's
looking
not,
for that as the holy grail.
yeah, there's nothing in the Leon about AI at all. I recently reread the whole article. And I don't know if anybody's doing work into this. There must be. I'm not aware of it. I think I've actually thought about this. I think the impedance actually lends itself beautifully to AI because it's all about pattern recognition. So if you can teach the software how to recognize the patterns, then you could save yourself a lot of time. So this impedance to look not just for reflux events, but also air events takes a lot of time. It took me about 3-4 hours to analyze that single study, which is not really time I have to really spend sitting looking at one study. So if I could get AI to do it accurately, that would be great. I'm sure it's going to come. There hasn't been much written about it at the moment.
Any other questions from anyone? Please put your hand up, or it would be very interesting to know how many of you are actually doing this in your practice or would refer your patients for it if you had access to it. Would anybody from the, shall we say, under-resourced countries like to tell us what they have at in their clinics? Perhaps Anusai, could you, if you're there, can you let us know what you do have in the way of manometry and pH impedance measurement, if you're still there?
Yes, good afternoon. Yeah, so this is something that we're still working on. We don't have it yet, but it's work in progress.
Yeah, I think it's, especially if you're trying to develop surgical expertise in these operations, because there are fewer reflux operations being done now, and I think generally speaking, wise surgeons are a bit more picky about who they operate on than they used to be when laparoscopic reflux surgery was first introduced. So I think it's a good thing to develop if you're developing or to try and get access to. Christian, do you have access to it in Cameroon?
In our setting, we have only pH metry, no impedance metry, and it helps us a lot in determining why if the patient has a real reflux or not, but we should progress in this field, and it's helpful for all these heartburn we have here, and we are trying to implement new machines in many settings in Cameroon.
Yeah. So I think it is, even in South Africa in the state sector, it is a resource that's largely confined to the tertiary hospitals. It's not available, to my knowledge, in any of the regional hospitals. And again, I think in private, its access is not universal, so probably more so. And I think there, again, if you go to these major physiology GI units, they have specialist technicians who are doing them day in, day out on lots of patients. So they become much more familiar with doing the technique properly rather than interpreting the software. And the software is only as good as the examination has been conducted. And I think that's something that you want to bear in mind if you're setting up these things, is to try and visit one of these high volume physiology places in UK or in and even the expertise that exists here, because it's only if you do that that you will get better at it and not misinterpret it, for sure.
Yeah, I think I have to echo that. I've done a recent course with UCLH in London, and they've got 4 physiologists. So those are technicians that just run the tests. So they can do 10, 12 procedures a day. And then they have 3 even 4 gastroenterologists who are neurogastroenterology trained, who have an interest. So it's a very big unit. We don't have that, of course. Nobody in Africa can have that. But I do think it's important to do enough volume of this, if it's possible, but also apply your mind. I think one cannot just be a technician and just spew out what the machine tells you. You have to apply it to your patient, and you have to think clinically, because often the clinical question is the most important thing in these patients, not so much what the test shows. You have to actually answer the clinical question. Is this reflux? And are the symptoms being caused by the reflux? And
yeah. And I think one of the other aspects that I think there needs to be liaison with gastroenterologists. Often surgeons are the primary interaction with some of the patients with reflux.
Yeah.
And I think often that these patients really should have their anti-secretory medication controlled properly and monitored properly, and to see that they're responsive before you consider surgery. In my view, there's no real rush to enter into reflux surgery. Your patient, you must really evaluate your patient in terms of symptom response to PPI and effective PPI therapy. So any of the hardcore physicians here what advice do you give your patients who have refractory GORD, or whose symptom response isn't quite what you would expect, even if they have proven acid reflux? Who's there? Is Reed there? We got some senior gastroenterologists on the call. Reed, are you still there? You were earlier on. Surely there must be someone who's more knowledgeable medically than us, Matt.
I was hoping so.
Yeah.
I don't think Reed Ali is there anymore.
Yeah, he would be. Are you still? Yeah. I think we'll have to leave that one for. But if you're a surgeon, Christian, did you have some words of wisdom on optimizing PPI therapy in refractory GORD?
Yes, is what we do every time, because I told you that we have this machine only in 2 hospitals in Douala and Yaoundé, and all the rest only do tests with PPIs and anti-reflux medicines, and they give the results. But some patients need to be operated, and in those cases, we need to have a pH metry before deciding that, and we operate a very few patients, and we got good results. So for many of our gastroenterologists, they only have to do testing with PPIs and before deciding.
Thank you. So I think we've definitely had an insight into pH impedance and its value, and I think the tricky step of labor-intensive interpretation of impedance. So I think that's been a valuable information for most of us on the participating in this echo session. So it remains for me to thank Matt for putting this together and explaining it very well and giving it context with clinical cases. And I think the this is definitely something you want to do your homework on. I'd like to thank India Echo for hosting us, the girls for putting everything together and making sure that we record this. And remember, it will be on the pediatric, it will be on the Gastro Foundation website. And next week, I believe, is pediatrics. So for all those who are managing pediatric gastroenterology, please tune in next week. Again, thanks to everyone for attending, and have a good evening.